Hello, I'm Dr. Bill Gradishar, Professor of Medicine at Northwestern University in Chicago, and I'm pleased to be participating in this Yerbba YouTube video discussing the use of molecular testing and how that might apply to patients with breast cancer. When we think about molecular testing, I think we have to go back one step and understand what we learn when a patient is initially diagnosed. Obviously, we determine the appearance of the tumor cells under the microscope, and then we do some additional baseline testing looking for hormone receptors, that is estrogen and progesterone receptor, as well as HER2. And these are the three elements that are common to every pathology report that we get. And again, additional things that may also be included are something called Ki67 or S phase or proliferation. And this also tells us how rapidly the tumor cells are dividing. And it gives us some insight into the behavior of the tumor. But that's at a very high level. Those are the things that we see in any pathology report. When we start talking about molecular testing, it can be thought of in a variety of different ways because we use these tools for different things. So in patients with early stage breast cancer, the molecular testing that is commonly done includes genetic testing, which looks at germline analysis to determine whether or not you have a propensity or family propensity to develop breast cancer or other cancers. And these are things like BRCA1 and 2 mutations, as well as some less common ones that could occur in certain patients. Knowing that provides two things. One is this a patient who has a high risk of developing breast cancer or other cancers? And it would also potentially apply to other family members not yet diagnosed with cancer who could have an elevated risk. So in the appropriate patient, genetic testing is important for those reasons. The other thing is, depending on the amount of disease a patient with early stage breast cancer has, if they also harbor a germline mutation such as BRCA1 or 2, it could influence the type of therapy that we recommend to the patient, particularly with respect to so-called PARP inhibitors, a specific kind of drug that's useful in patients with BRCA1 and 2 germline mutations. So this information is molecular testing. Now, the other kind of molecular testing that's not infrequently done in patients with early stage disease is called testing that helps us determine whether or not there'd be a benefit from chemotherapy. And these are tools such as the recurrence score, the 21 gene recurrence score, or the MammaPrint test, a 70 gene assay. And these are tools that we use in patients most commonly with hormone sensitive early stage breast cancer, asking the question whether or not the addition of chemotherapy to anti-hormone therapy will further reduce the risk above and beyond what anti-hormone therapy can provide. And there's a lot of nuances that go into interpreting these tests. We have to take into account the age of the patient and other factors, but it is proven very useful to help us determine, particularly in node-negative ER-positive patients, whether chemotherapy adds any benefit whatsoever. And that's been most widely applied with the recurrence score, which is a tool that is evaluating the tumor tissue, not the patient, but the tumor tissue. And it tells us, in addition to anti-hormone therapy, will chemotherapy add any additional benefit? And it looks at the risk of metastatic disease essentially 9 years downstream from the diagnosis. So patients that have a very low score, they're not going to need chemotherapy, whereas if the number came back high, we would be more inclined to consider chemotherapy. And similarly, if you look at MammaPrint as another example, you can also differentiate those patients who are at higher risk, having a poor prognosis, where chemotherapy might be recommended. Now, again, with these tests, we have to take into account the age of the patient. Are they pre or postmenopausal? These factors all figure in. And then we also have some information based on clinical trials that these tools can be applied even to patients with higher risk node-positive disease if their tumor burden, meaning the nodal status, is still fairly minimal, 1 to 3 nodes. And that also may help us determine, particularly in postmenopausal patients, whether or not chemotherapy adds anything to anti-hormone therapy. As a consequence of using these tools, these molecular tests, we've decreased the number of patients who actually need chemotherapy compared to, say, 20 or 30 years ago, where almost everybody got chemotherapy. Now we can discriminate and identify those patients who can avoid it or really need it. And that has resulted in much better care, much more tailored therapy for patients with early stage breast cancer. These tools also are useful as a prognostic indicator. They help tell how a patient will do over the long term, but their most important value added is determining whether or not chemotherapy is needed. There are a variety of other tests like that. Those are the two most commonly used, but there are others, Prosigna, EndoPredict, BCI, other tests that can give us some sense of prognosis, how a patient will do over the long term in terms of risk of recurrence. Some of these tools may help us determine whether extended anti-hormone therapy beyond 5 years is useful. The BCI test is one such tool that can be used for that purpose, trying to understand if therapy with anti-hormone therapy beyond 5 years should be recommended, or if you could discontinue at 5 years without any hazard to the patient. If you'd like to gain more information about your personal situation and personal treatment paths, including the variety of different therapies that could potentially be appropriate for you, the tumor biology in your case, as well as taking into account your personal health profile, go to Yerbba.com. The Yerbba report also breaks down the different treatment options that are available, as well as the expected side effects that may be seen with those therapies. Yerbba medical experts directly can access evidence-based answers for your questions, discussing options, recurrence risk, and side effects of therapy. Simply go to Yerbba.com, and I look forward to speaking to you again in the future. Now, a completely different topic in a sense, but still molecular testing, is for patients with metastatic disease. We do what's called NGS testing, or somatic evaluation of the tumor, not so much the germline, which is our individual chromosomes, but looking at the tumor tissue or the circulating tumor DNA to understand whether specific mutations are present. And if they are, they may be what we refer to as actionable. Actionable means that we may have a drug that could be addressing that specific mutation. And there are many different examples of that now in breast cancer. For instance, in patients that develop what we call estrogen receptor mutations, ESR1 mutations, we know that those patients are typically more resistant to standard endocrine therapies. And we now have newer drugs that are effective in patients who have ESR1 mutations. And knowing that would help us tailor the therapy appropriately for a patient. The other important point is that these mutations can arise over time. So if you evaluate a patient at time point A and there's no mutation, specifically with respect to ESR1 mutations, if you went back 9 months later when a patient had a new challenge and their disease had progressed, you'd want to evaluate again to determine if that ESR1 mutation had developed. There are also other mutations that can develop, including PI3 kinase, AKT, PTEN mutations. And if you see mutations in these pathways, we have drugs that can be used to tailor the therapy for that specific mutation. So patients with PI3 kinase, AKT, PTEN abnormalities, we have drugs that are usually partnered with anti-hormone therapy and have been shown to be very effective above and beyond what anti-hormone therapy alone can do. So this information has become much more relevant and results in a much more tailored approach to an individual patient. PI3 kinase mutations, as an example, are things that are usually there right from the beginning, as opposed to ESR1 mutations that can evolve under pressure of treatment. So we get testing and we're looking for these mutations because it allows us to use specific drugs if those mutations are present. So I think the key takeaways on this video are that molecular testing is a very contemporary tool that we use in patients with both early stage and advanced stage breast cancer. For patients with advanced disease, it's critically important because we now have specific drugs that we use in certain settings depending on whether a mutation is present. Sometimes these are partnered with anti-hormone therapy. Sometimes they're used in the example of immunotherapy if the PD-L1 status is elevated. In early stage disease, we're starting to see many of the drugs that we now use in the advanced disease setting slowly migrate to earlier stages of disease, but we don't use those drugs yet. Nonetheless, molecular testing is important because we need to know BRCA1 and 2 status of the patient, because that may determine not only risk for the patient or their family members, but also for individual patients at high risk require the need for adding a PARP inhibitor as a component of their adjuvant therapy. So all of these things have really been a sea change in how we approach patients with both early and late stage disease.